Welcome to the podcast, where great minds meet. We're so glad you're listening. Where Great Minds Meet brings together visionary guests, from Chancellor Gary May and Dr. Robert Langer to Greg Zuckerman of the Wall Street Journal and Forbes 30 Under 30's Kyle Wum, to share insights on science, leadership, and purpose. Featuring pioneers like His Excellency Sidney Colley and Dr. Emery N. Brown, each episode dives into stories of resilience, discovery, and impact, celebrating the intersections of curiosity and greatness across diverse fields. Thanks for listening.
Podcast series where we interview some of the most brilliant and influential minds in their fields and with their crafts. We've interviewed the likes of Dr. Robert Langer, co-founder of Moderna, Chancellor Gary May, a leader in academic administration. We've interviewed ambassadors, and now we have one of the
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Welcome to our deep dive. Today we're going to be tackling the crucial role of renal clearance in medication dosing.
All right.
Especially in those high-stakes critical care situations.
Yes.
We've got a really fascinating mix of sources here to guide us.
Yeah.
Medical textbooks, journal articles, clinical guidelines for practical application, and even some sample exam questions.
Oh, wow.
To test our knowledge.
I like that. It's like we have all the pieces. It's like having a toolkit, for understanding how these kidneys impact medication levels, and especially when things get complex in critical care.
Absolutely. And, one scenario from the source material really caught my eye.
Okay.
Imagine a patient in septic shock needing norepinephrine.
Yeah.
Getting that dose right
Yeah.
can be the difference between life and death.
Oh, yeah.
And that's where understanding renal clearance becomes absolutely critical.
Absolutely. You got to know how the kidneys are filtering those medications from the bloodstream.
Right.
Any changes to that kidney function can significantly alter how our body's processing those drugs.
Exactly. And that's what we're here to unpack today.
Yeah.
Right?
Yeah.
How these different disease states impact dosing, what red flags to watch out for in clinical practice.
Yep.
And how to use this knowledge to make informed decisions.
Yeah, I think a good place to start would be just to kind of set the stage with like a quick review of hemodynamics, like all the forces that play in our circulatory system. And the source material provides this really helpful table of normal ranges for key parameters, like blood pressure, heart rate, cardiac output, all that good stuff.
Those normal values, they're like our baseline. Right. But like you were saying, things can get complicated
for sure.
pretty quickly. So let's talk about shock.
Okay.
Specifically septic shock and cardiogenic shock.
Okay.
Those are kind of the major players in critical care.
For sure.
So septic shock.
Septic shock. Yeah. So that's a life-threatening condition triggered by the body's response to infection.
Right.
It can lead to some pretty serious consequences, like organ damage and dangerously low blood pressure.
And the source material really emphasizes norepinephrine as the go-to vasopressor for septic shock.
It is the first-line agent, and it makes sense because it constricts those blood vessels, raises that blood pressure.
So it's about buying time for other treatments to work.
Exactly.
And if norepinephrine alone isn't cutting it,
if it's not enough,
then vasopressin can be added. And in those truly refractory cases, then you might consider epinephrine.
Yeah, you go down the line, you got your
norepinephrine, and then you got vasopressin, then you got your epinephrine, so you got kind of like an
escalation of care.
An escalation.
And the source material does a great job of outlining that.
Yeah, it's a good guide.
But it also stresses the importance of understanding like why each medication is chosen and how it works.
Absolutely. You don't just want to memorize a protocol. You want to understand the physiology behind it.
Now let's switch gears to cardiogenic shock. Another scenario where the blood pressure plummets. But this time, the heart itself is a culprit.
It's a pump problem. The heart can't pump enough blood to meet the body's demands.
And often due to a massive heart attack or severe heart failure.
Right.
And you know what's interesting is the source material highlights all these various definitions of cardiogenic shock.
Right. There are a lot of...
From like the SHOCK trial criteria to the SKII classifications.
Yeah, all sorts of ways to define
It's a good reminder that medicine isn't always black and white.
Nope. Lots of gray areas.
Right.
Yeah.
It underscores the complexity of this condition.
Yes.
And the importance of recognizing these subtle variations in how it presents.
For sure.
One statistic from the source material that really struck me is that the survival rates for different acute heart failure syndromes can vary drastically.
Yeah, they do.
It really highlights the gravity of the situation.
It does. It shows the need for early recognition and aggressive management.
But let's bring this back to our main focus, renal clearance.
Okay, yeah.
How do these shock states impact the kidneys and ultimately medication dosing?
Right.
Yeah. So, okay, let's break it down.
Right.
Think of the kidneys as the body's filtration system, right?
Yeah. Yep.
Constantly removing those waste products.
Yeah.
Excess fluids, including medications.
Right. And when those filters aren't working at full capacity, that's where things get tricky with the drug dosing. So imagine our patient in septic shock. If their kidneys are impaired, they might not clear norepinephrine as efficiently. And that could lead to a stronger response to the medication. But it also increases the risk of side effects.
So it's this balancing act.
It's a balancing act. That's where the real learning comes in. Is understanding how to adjust the medications based on that renal function to strike that balance between efficacy and safety.
So let's put this knowledge into practice.
All right.
Our source material includes some pretty challenging exam questions that focus on dosing adjustments in patients with renal impairment.
I like that.
These questions really force us to apply what we've learned about decreased renal function and drug elimination. Like, how do we adjust the doses to avoid harm?
That's the key question. That's what we want to know.
For example, one question dives right into the deep end. Dealing with norepinephrine dosing in a patient with septic shock and underlying kidney disease. And it really makes you think critically about the interplay of those two factors.
It's about connecting the dots. You got your theoretical knowledge, and then you got your real-world application, which is
bringing it all together.
Exactly. It's what this deep dive's all about.
So now let's get specific.
Okay.
Our source material provides a really comprehensive list of drug classes where renal function plays a crucial role in dosing adjustments. We're not just talking about like random medications here. These are commonly used drugs in various clinical settings. And what's great is that the sources provide practical tables and examples illustrating how specific drugs are affected by changes in renal clearance.
I love a good visual aid.
Me too.
Yeah.
So a good place to start is with ACE inhibitors and ARBs. Medications frequently used for heart failure. Dosing can be a real challenge in those patients with impaired renal function.
It can be.
The tables in our source material clearly outline how creatinine clearance, which is that measure of kidney function, dictates the appropriate dose for these medications.
It really is like a roadmap. You know, you're navigating these tricky dosing adjustments, making sure we're providing the right amount to achieve the effect we want without putting the patient at risk.
Exactly.
It's all about individualized therapy.
Yes.
One size doesn't fit all. Especially when it comes to this renal function and drug metabolism. You know, it's fascinating how seemingly small changes in that creatinine clearance can have a big impact on dosing. But beyond ACE inhibitors and ARBs, we have beta blockers, another essential tool in heart failure management.
Beta blockers are interesting because the source material really emphasizes this like slow and steady approach to dosing. Especially in patients with compromised renal function.
Gradual up titration. Careful monitoring are key to avoiding complications. It's a reminder that we're not just treating, you know, a disease. We're treating a person. And each person responds differently to medications.
Speaking of individualized therapy, diuretics especially in acute decompensated heart failure,
Right.
require that same careful consideration.
You're right. Aggressive diuresis might be necessary to get rid of that excess fluid.
Right.
But we have to balance that with the patient's overall kidney function and those electrolyte levels. The source material gives us some insightful case studies that illustrate this delicate balance.
One that stands out involves a patient with acute decompensated heart failure and pre-existing chronic kidney disease. The challenge was finding that optimal diuretic dose to relieve congestion without further compromising their renal function.
Exactly. It's about using that textbook knowledge, but also considering those individual circumstances and comorbidities.
Right. So it's not just what's in the books, but also using your clinical judgment.
It's where the clinical judgment comes in.
Yeah. And our deep dive covers a wide range of these clinical scenarios.
That's great.
Really helping us connect those dots between theory and practice.
And the list goes on, right?
Yeah.
We've got antiarrhythmic drugs, the ones used to treat those irregular heartbeats.
Right.
Those can also pose challenges in patients with renal impairment. Yeah. So the source material breaks down this Vaughan-Williams classification. It's a system for categorizing these drugs. And it helps us identify which ones require those dose adjustments based on kidney function.
It's like having a cheat sheet.
Yeah, exactly. It's a cheat sheet for navigating this world of antiarrhythmic therapy.
Yeah. The source material even includes a table.
Oh, nice.
Summarizing the renal adjustments for commonly used antiarrhythmics.
I like that. That's helpful.
It is.
All right. So we've talked about antiarrhythmics.
Yeah.
What about anticoagulants? Those are essential for preventing blood clots in various clinical situations. So our sources provide a great comparison of unfractionated heparin, low molecular weight heparin, and fondaparinux. Each of those has its own nuances in dosing and monitoring based on renal function.
It's fascinating how even within a drug class, those subtle differences in the pharmacokinetics can necessitate those significant adjustments based on renal clearance. The source material really does a good job of diving
it is a deep dive
into these nuances.
It does.
And let's not forget about statins for dyslipidemia.
Oh, yeah. Good point.
While they're generally well tolerated, the source material highlights the importance of careful statin selection in kidney transplant recipients due to those potential drug interactions.
Very important point.
It's a reminder that those renal clearance considerations extend beyond just critical care and impact various specialties.
They do.
But, it's not just about memorizing these drug lists and dose adjustments.
No.
It's about understanding.
You got to know the why.
The why behind it all.
Absolutely.
Right.
Yep.
And that's where the discussion of lab monitoring and the physical exam comes in.
Okay.
Right.
Yeah.
These tools really help us assess renal function, monitor for drug side effects, and ultimately guide those clinical decisions.
That's what we use them for.
So our sources emphasize serum creatinine and estimated glomerular filtration rate, or EGFR, as those key indicators of kidney function.
Right. These tests give us that quantitative measure of how well those kidneys are filtering waste products from the blood.
And it's not just about the number itself.
No.
But how it changes over time.
That's important.
A sudden jump in creatinine, for example, could signal acute kidney injury, requiring prompt attention and potential adjustments to medication regimens.
It's like you're piecing together a puzzle. You got your lab values, you got the patient's history, you got their presentation, all comes together to give you that complete picture of their renal function.
The source material also mentions a whole bunch of other lab tests that might be relevant, depending on the clinical scenario.
Right. There are a lot of other factors.
Like potassium, troponin, CKMB, BNP, lipid panel, just to name a few.
Just to name a few. And each of those tests gives us a glimpse into a different aspect of the patient's health.
Right.
Understanding their significance in relation to renal function and medication dosing is crucial.
Let's take potassium, for example.
Okay.
An electrolyte vital for heart function.
Yes.
Primarily excreted by the kidneys.
That's right.
Impaired renal function can lead to difficulty eliminating that potassium, potentially causing hyperkalemia.
Right, which can be dangerous.
Which can lead to all sorts of...
Like heart rhythm disturbances.
Exactly, rhythm disturbances.
And it's especially important to consider when prescribing medications like ACE inhibitors.
Yep.
And ARBs.
Right.
Which can further increase those potassium levels.
That's right.
And the source material even has a helpful table outlining the risk of hyperkalemia with different medications in the setting of renal impairment.
That's a good resource. So it's all about recognizing those potential drug interactions.
Yes.
Right.
Yeah.
And being proactive in monitoring for those electrolyte abnormalities.
For sure.
But beyond lab tests, our sources emphasize the importance of the physical exam.
Right, Don't forget to actually examine the patient.
You still got to lay hands.
You got to put your hands on the patient.
Sometimes the most valuable clues come from direct observation.
Right. The source material highlights specific physical exam findings that might indicate organ dysfunction or drug side effects.
Right.
Like pulmonary crackles.
Yeah, pulmonary crackles could be a sign of fluid overload.
Right, fluid overload.
In the lungs.
An S3 gallop.
Oh, okay.
Extra heart sound that could be a sign of heart failure.
Okay.
Or even something as simple as cool extremities.
Okay.
Which might indicate poor circulation, potentially related to shock.
Right.
Or heart failure.
And we can't forget about peripheral edema. Oh, yeah, the classic swelling in the legs or feet. A classic sign of fluid retention.
That's a good one.
It is a good one.
One finding that always catches my attention is jugular venous distension.
Oh, absolutely. It's like a window into the pressure within the veins of the neck.
Right.
Potentially indicating fluid overload or heart problems.
And the source material actually provides some helpful diagrams.
Oh, nice.
Illustrating how to properly assess jugular venous distension.
Those visual aids are so helpful.
They are.
For really solidifying the understanding.
Yeah.
And finally, we can't forget about listening for bruits.
Oh, yeah.
Those whooshing sounds that can signal turbulent blood flow.
Right.
Which can be a sign of arterial narrowing.
It's like having a built-in stethoscope.
Yeah, exactly. Built-in stethoscope. And the source material even includes those audio clips of different types of bruits, which is super valuable for learning to identify them.
Yeah.
So it's all about honing those clinical skills, right? Using all those tools at our disposal to really assess those patients comprehensively.
So the physical exam, far from obsolete.
Far from obsolete.
Right?
Yeah.
It's a powerful tool.
It is powerful.
That when combined with the lab data and clinical reasoning, allows us to tailor that approach to each individual patient.
It's like becoming a medical detective, isn't it?
It is.
Piecing together all those clues from the history, the physical exam, the labs, to try to figure out what's going on with our patients.
And that's what makes medicine so challenging.
Absolutely.
And rewarding.
Right.
Right.
Yeah.
It's not just about applying those algorithms or memorizing facts.
Yeah.
It's about using our knowledge and skills to care for real people with complex needs.
Speaking of complex needs, we've focused a lot on the heart and the kidneys.
Yeah.
But renal clearance can impact a wide range of medications.
Oh, absolutely.
Used across various specialties.
Yeah, it's not just cardio and renal.
That's right.
It's everything.
That's a great point.
Yeah.
The source material provides several examples of this.
It does.
Including statin use in kidney transplant recipients.
Right. So statins are commonly prescribed to lower cholesterol and reduce that cardiovascular risk. But in patients with kidney transplants who are already taking those immunosuppressant medications to prevent organ rejection, statin selection becomes really important.
Right, because certain statins can interact with those immunosuppressants.
Exactly.
Potentially leading to some serious side effects like muscle breakdown or even kidney damage.
Right.
It's a perfect example of how those renal clearance considerations extend beyond critical care and impact the whole
spectrum of medicine. Yep.
It's a reminder that we need to be aware of those potential interactions and adjust those medication regimens accordingly.
Yeah, and it highlights the importance
of that interdisciplinary collaboration.
Yes.
Working with our pharmacists,
absolutely,
other specialists to ensure safe and effective medication use.
We're all on the same team, right?
We're all on the same team, working towards that common goal of providing the best possible care for our patients.
And speaking of teamwork, the source material also emphasizes the role of pharmacists in optimizing medication therapy in those patients with renal impairment.
Absolutely. Pharmacists are invaluable resources.
Yes.
Especially when it comes to pharmacokinetics.
Right.
The study of how drugs move through the body. They can help us understand how renal function impacts drug absorption, distribution, metabolism, excretion.
Yeah.
They can help us tailor the regimens based on the patient's individual needs.
They're like the meditation gurus.
They are. They're the medication gurus that help us navigate the complexities of drug interactions, dosing adjustments, therapeutic monitoring.
Their expertise is essential.
It is.
In ensuring medication safety and efficacy, especially in those patients.
Especially in those patients.
With compromised renal function.
Absolutely. It's about recognizing that we don't have to have all the answers.
Right.
There are experts in different fields that can provide valuable insight and support our decision-making.
Collaboration is key.
Collaboration is key.
Speaking of some challenging decisions, let's switch gears and talk about some of the ethical and clinical dilemmas associated with renal clearance and drug dosing.
Okay.
Our sources touch on some pretty thought-provoking topics.
Right.
Like the use of corticosteroids in septic shock.
Yeah, that's a good one. So the source material presents conflicting evidence from trials like Corticus and Adrenal, which leaves us with a little bit of a gray area when deciding whether or not to use corticosteroids in these patients.
So it's a great example of how medical research is constantly evolving. And what was once considered standard practice can change as new evidence emerges.
As new evidence emerges. That's the beauty of it.
But it also emphasizes the importance of that shared decision-making.
Absolutely.
Where clinicians and patients work together to weigh the potential benefits and risks of treatment options, especially when the evidence isn't totally clear.
Right. It's about respecting that patient autonomy, you know, making sure that they are involved in those decisions about their care.
And speaking of gray areas, the source material also discusses the FDA warning about hydroxyethyl starch.
Oh, right. Yeah.
Reminding us that even seemingly harmless therapies can have unintended consequences.
They can. That warning linking hydroxyethyl starch to increased mortality and renal injury in critically ill patients really shook the medical community.
Yeah, it did.
It's a reminder that we always have to critically evaluate that evidence, even for those therapies that seem safe and established.
So it really underscores the importance of that ongoing vigilance, right?
Yes.
Carefully considering the potential benefits and risks of any intervention and being open to reevaluating our practices based on new information.
Based on new information.
So these ethical and clinical challenges really highlight the complexity of medicine
They do.
and the need for that constant learning and adaptation.
It's not just about knowing the science, right? It's about understanding the human element. Considering those individual patient values and preferences and navigating those difficult decisions with compassion and humility.
It's about caring for the person.
It's about caring for the person.
So as we move into the final part of our deep dive, let's reflect on what we've learned and how it can be applied to our own clinical practice and research.
We've covered a lot of ground in this deep dive, exploring all the complexities of renal clearance and drug dosing in critical care. But it's not just about absorbing all this information. The real power is applying it to real-world situations.
Yeah, think about those patients that you encounter every day. How can understanding this renal clearance change your approach? How can you use this knowledge to improve those outcomes?
Like, let's say you're managing a patient with septic shock.
Okay.
And you notice that their creatinine level has been creeping up.
Yeah.
What alarm bells go off in your head?
Right.
How do you adjust their medication regimen to prevent potential harm?
That's where the rubber meets the road, right?
Yeah.
Recognizing those subtle signs.
Right.
Interpreting those lab values.
Yeah.
And making those informed decisions about medication dosing.
And the source material provides a ton of practical tips and strategies for doing just that.
For example, one section highlights the importance of calculating that creatinine clearance accurately, especially in elderly patients, where that age-related decline in kidney function can be significant.
That's a great point. We can't just rely on that serum creatinine alone.
Right.
Can be misleading in certain populations.
Sure.
The source material even gives us a handy formula for estimating that creatinine clearance, taking into account age, weight, and gender.
So it's like having a personalized dosing calculator.
Like a personalized dosing calculator.
Yep. And speaking of personalized medicine, the source material touches on the concept of therapeutic drug monitoring.
Yes.
Where we actually measure drug levels in the blood to guide dosing.
That's right. That's becoming increasingly important, especially for those medications with a narrow therapeutic index.
Okay.
Where that difference between an effective dose and a toxic dose is small.
Right.
The source material gives us some really insightful examples.
Of how therapeutic drug monitoring can be used to optimize drug therapy in those patients with renal impairment.
It's fascinating how we can use technology and lab testing to fine-tune those medication regimens and ensure we're achieving that desired effect while minimizing the risk of those adverse events.
It's about using the tools that we have to individualize therapy and provide the best possible care for our patients.
And as you continue on your learning journey, think about how you can incorporate these concepts into your own practice or research. Are there specific areas you want to explore further?
Yeah, there are questions that have emerged from this deep dive.
Don't be afraid to dig deeper, consult with colleagues, and stay curious.
That's how we learn.
The more you learn, the better equipped you'll be
to
navigate all these complexities of renal clearance and medication dosing. One question that's been swirling in my mind is,
as we move towards a future of personalized medicine, where we can tailor treatments to each individual's unique genetic makeup and physiological characteristics, how can we leverage our understanding of renal clearance to optimize drug therapy even further?
Oh, that's a fantastic question.
Right.
Imagine a world where we can predict how an individual's kidneys will metabolize a specific drug based on their genetic profile.
Right.
We could then adjust that dose preemptively, minimizing the risk of adverse events, maximizing that therapeutic efficacy.
It's pretty incredible to think about those possibilities.
It is.
But even without that futuristic technology, we can still make a significant impact.
We can.
By applying what we know from this deep dive, being mindful of renal function, monitoring for drug interactions, and individualizing therapy.
That's it.
We can improve patient outcomes and make a real difference in people's lives.
That's what it's all about.
It all comes back to those core principles of medicine.
True principles,
Careful observation, critical thinking, and a deep commitment to our patients' well-being.
That's the heart of medicine.
That's what it's all about. And that's what this deep dive has been all about.
It has.
So as we wrap up this exploration of renal clearance and drug dosing, remember this. Knowledge is power. But only when it's put into action.
Absolutely.
Use what you've learned today to ask questions. Challenge assumptions.
Challenge those assumptions.
And strive to provide the best possible care for your patients.
Keep learning, keep growing, and never stop questioning.
Absolutely. Because in the world of medicine, the pursuit of knowledge is a lifelong journey.
It is.
And it's a journey worth taking.
It is. Thank you for joining us on this deep dive.
Yes.
We hope you found it insightful and empowering.
And until next time, keep those minds engaged. Diving in today, we're tackling hemodynamics, sepsis, and how to manage meds for cardiovascular conditions, especially when kidneys are involved.
And not just the what, but the why. How to calculate those key numbers and use those calculations to make treatment decisions.
Connecting those dots, making this knowledge practical. Love it. Let's start with hemodynamics, those vital signs and calculations, the window into the heart and blood vessels.
Like puzzle pieces. They fit together to tell us how the circulatory system's doing. We'll start simple, systolic blood pressure, SBT, the top number, normally between 90 and 140. And diastolic, DBP, the bottom number, normally between 60 and 90. Then we have some more specialized measurements.
Like what? What's really important?
Arterial pressure, MAP. The average pressure in the arteries, a more complete picture than SBP or DBP alone, normally between 70 and 100.
I bet there's a formula.
Right. MAP equals SBP plus 2 times the DBP, all divided by 3.
So it's related to those familiar blood pressure readings. Why is it so important clinically?
Tells us how well the organs are being perfused. If it's too low, vital organs, the brain, kidneys, might not get enough blood flow. Damage.
But if it's high?
Strain on the heart and blood vessels. Risk of complications like stroke or heart attack.
So MAP, it's like a key indicator if the body's getting enough oxygen and nutrients.
Exactly. Now, heart rate, HR. Number of times the heart beats per minute. Normal resting, usually between 60 and 80.
Straightforward. But how much blood is the heart pumping? Cardiac output must be important.
You got it, CO. How much blood the heart pumps each minute. Normal is usually between 4 and 7 liters.
Higher output, the heart's doing its job. But it must depend on the person's size, right?
That's where cardiac index comes in, CI. Body size is factored in, more accurate regardless of build.
Personalized cardiac output, how do we calculate that one?
Cardiac output divided by the patient's body surface area. Normal's 2.5 to 4.2 liters per minute per square meter.
Low CI.
Not pumping enough blood for their size. Could be a problem. Now, zooming in on each heartbeat. Stroke volume, SV. How much blood is ejected with each beat? Normally around 60 to 130 milliliters.
Weak heart, low stroke volume, not enough blood squeezed out with each beat. How do we calculate stroke volume?
Cardiac output divided by heart rate. Simple, but tells a lot about the heart's efficiency.
Makes sense. Now, I'm thinking the heart works harder if there's resistance in the blood vessels. That's where systemic vascular resistance comes in. SVR.
Absolutely. SVR measures the resistance, how hard the heart has to push blood through the system. Normal's between 800 and 1200.
That's a mouthful. High SVR, constricted blood vessels, heart's got to pump harder.
Exactly. Could be a sign of hypertension or vasoconstriction. Now, pressure within the heart itself. Pulmonary capillary wedge pressure, PCWP, reflects pressure in the left atrium, normally between 5 and 12.
So PCWP, inside into the left side of the heart, if it's elevated.
Heart failure or mitral valve stenosis. Could be.
You got it.
Finally, central venous pressure, or CVP. It measures the pressure in the vena cava, that big vein returning blood to the heart. Normal's 2 to 6.
So CVP, it tells us about the pressure on the right side, high.
Right-sided heart failure or fluid overload? Maybe.
Understanding these parameters, their normal ranges, and how to calculate them, that's essential for assessing a patient's cardiovascular status to make good treatment decisions.
It's like having a detailed map of the circulatory system. With pressure gauges and flow meters at all the important points, everything's connected.
Great analogy. Now, let's switch gears. Sepsis and septic shock.
All right.
Sepsis, major health concern. Septic shock, the most severe stage, life-threatening. It's like an infection gone wild, wreaking havoc on the entire body.
You could say that. Sepsis is a dysregulated host response to an infection. It can lead to organ dysfunction. And when it progresses to septic shock, the circulatory system starts to fail. Cells don't get the oxygen they need.
And managing septic shock, it's got to be quick, right? Strategic. What are the steps, especially those early interventions?
First, right away, fluid resuscitation. Restore blood volume, improve circulation. We usually start with crystalloids, solutions of water and electrolytes, like normal saline.
Why crystalloids? What makes them the go-to?
Readily available, pretty inexpensive, effective at expanding blood volume quickly. But we have to watch out for fluid overload, especially in patients with kidney issues.
Right. If the kidneys aren't filtering well, those fluids build up. Problems. What are the other options? If crystalloids aren't enough, or if we're worried about fluid overload?
We might consider colloids, solutions with larger molecules that stay in the bloodstream longer, expand blood volume more rapidly, but they're more expensive. Potential side effects too, kidney damage, bleeding.
Weigh the benefits and risks. Each patient's individual needs. Underlying conditions. What about blood products? When do those come in?
Blood products like packed red blood cells or fresh frozen plasma when we need to restore oxygen carrying capacity, improve clotting function.
Makes sense. So fluid resuscitation, check. What's next? Vasopressors. Medications that constrict blood vessels and increase blood pressure. Essential for septic shock, when fluids alone aren't enough.
This is where it gets interesting. What's the first-line vasopressor?
Norepinephrine. Our go-to in septic shock. It stimulates alpha-1 receptors, vasoconstriction, increased blood pressure. It also has some effect on beta-1 receptors, which can increase heart contractility and heart rate.
A two-pronged attack, tightening those blood vessels and boosting the heart. Typical starting dose. And how do we adjust based on the patient's response?
We typically start at 0.01 to 0.03 micrograms per kilogram per minute. Titrate up or down, aiming for an MAP of at least 65. Monitoring, of course, for signs of improvement or for side effects.
And when norepinephrine alone isn't working, what else do we have?
We might add vasopressin. It's the antidiuretic hormone, helps the body conserve water. But at low doses, we use it for its vasoconstricting effects.
Reinforcements. How does adding vasopressin affect our norepinephrine strategy?
Vasopressin can help improve blood pressure when norepinephrine alone isn't enough. It might let us lower the norepinephrine dose too, minimize side effects.
That could be really important for patients with certain conditions, like coronary artery disease, right? Where too much vasoconstriction could be harmful. Now, what about epinephrine? Powerful drug, often used in emergencies. When do we consider it for septic shock?
Epinephrine, potent stimulator of both alpha and beta receptors, inotropic and vasoconstricting effects. We reserve it for those who remain hypotensive despite adequate fluid resuscitation and norepinephrine, with or without vasopressin.
Last resort, in severe cases. When the other vasopressors haven't been enough to restore blood pressure, typical starting dose. Key considerations for titration.
Typical starting dose is 0.05 to 0.1 micrograms per kilogram per minute. Careful titration, aiming for that MAP of 65, closely monitoring for improvement or adverse effects, arrhythmias, excessive vasoconstriction.
It's a balance, isn't it? Getting the blood pressure up and avoiding complications. Now, corticosteroids. I know they're sometimes used in sepsis management. I've heard there's some debate about their effectiveness. What's the latest?
There has been a lot of debate, yeah. Earlier studies suggested they might be a game changer in sepsis, but more recent large-scale trials like Corticus and Adrenal, they haven't shown a significant reduction in mortality in most septic shock patients.
So not a game changer after all. Have we ruled them out completely for sepsis?
Not entirely. Current guidelines, they advise against routinely using corticosteroids in septic shock unless the patient has persistent hypotension, despite adequate fluids and vasopressor therapy.
Targeted therapy then, not a standard treatment for everyone with septic shock.
Exactly. And when we do use them, the usual choice is hydrocortisone, 50 milligrams IVA every 6 hours.
Okay, I imagine managing septic shock isn't just about giving meds. It's constant monitoring, adjustments.
Absolutely. It's a dynamic process, monitoring vital signs, urine output, lactate levels, indicators of organ function, real-time adjustments as needed.
High-stakes chess match. Constant evaluation and strategic moves to stay ahead of the sepsis.
That's a good way to put it. Now let's switch gears again. Another challenging condition. Cardiogenic shock.
All right. Cardiogenic shock. Yeah. Kind of the opposite of septic shock, right? The circulatory system failing, but not because of infection, because the heart isn't pumping effectively.
Exactly. Cardiogenic shock, the heart can't pump enough blood to meet the body's needs. Life-threatening. Needs prompt recognition. Intervention.
How do we diagnose it? Are there specific criteria?
Yes. Several sets of criteria, each a little different, but they all focus on the idea of the heart failing to pump well, the body not getting the oxygen it needs.
Okay, so what signs and symptoms are we looking for?
One key indicator, systolic blood pressure less than 90 millimeter Hg for 30 minutes or longer, or needing support to keep it at or above 90. Persistent hypotension like that suggests the heart is struggling.
Low blood pressure, red flag. What else?
Evidence of end organ hypoperfusion. The organs aren't getting enough blood flow. This could look like low urine output, cool extremities, altered mental status, or elevated lactate levels.
So low blood pressure plus signs that the organs are in trouble.
Exactly. Now, there are subtle differences in how these criteria are applied in different trials and guidelines. The IABP SHOCK2 trial, for example, it includes pulmonary congestion as a criterion, fluid buildup in the lungs, a sign that the heart can't pump effectively.
It's not just about numbers, it's about the clinical context, too.
Absolutely. To classify the severity and progression of cardiogenic shock, we use the SCAI classifications. Stage A to Stage E.
Okay, let's walk through them. Stage A.
Stage A is at risk. Not in shock yet, but they have risk factors, a high risk of developing it.
Closer monitoring. Preventative measures. What are some of those risk factors?
Think recent heart attack, severe heart valve disease, or certain types of cardiomyopathy, conditions that can weaken the heart.
Okay, so Stage A is about identifying those who need extra attention. What about Stage B?
Beginning cardiogenic shock. They have hypotension, tachycardia, but no signs of hypoperfusion yet.
Low blood pressure, high heart rate, but their organs are still okay.
Yes. Stage C, classic cardiogenic shock. Hypotension and hypoperfusion. Interventions are needed, vasopressors, maybe mechanical circulatory support.
This is where it gets serious.
Right. Stage D, deteriorating cardiogenic shock. Those in Stage C who are getting worse, even with treatment.
Despite our best efforts.
Yeah.
And Stage E.
The most critical.
Yeah.
Extremists. Cardiac arrest. They need CPR or ECMO extracorporeal membrane oxygenation.
Wow, that's really serious. So these SDAI classifications, they help us figure out how bad the cardiogenic shock is.
Yeah.
And to tailor our treatment.
Absolutely. Now let's transition to medications used to manage these cardiovascular conditions.
Okay, drugs, lots to cover. Different drug classes, how they work, dosing, and renal adjustments. Where do we begin?
A good place to start is ACE inhibitors, cornerstone of cardiovascular pharmacology. Treat conditions like heart failure, hypertension. They block the angiotensin-converting enzyme, reduces angiotensin-tesic production.
So they relax the blood vessels, lower blood pressure, make it easier for the heart to pump.
Exactly. Some key drugs in this class, lisinopril and elapril and captopril.
Dosing, renal function is key, right?
Mm-hmm.
Adjust those doses to protect the kidneys.
Yeah.
Especially when renal clearance is impaired. Can you give us some examples?
Sure. Lisinopril. If creatinine clearance, CRCL, is greater than 50, normal kidney function, typical starting dose might be 10 milligrams once daily. But if their CRCL is between 20 and 50, we'd reduce it to 5 milligrams once daily. And if it's less than 20, we might start with 2.5 milligrams once daily, or even consider a different medication altogether.
So constantly adjusting based on how well the kidneys are filtering those meds.
Exactly. Balance, effectiveness, and safety, especially protecting the kidneys from medication overload.
This is fascinating to me. Figuring out the right dose for each patient, based on their individual situation, their kidney function. Like a puzzle. What about ARBs? They're similar to ACE inhibitors in some ways, right? How do they work? And how do we adjust the doses based on renal function?
ARBs, angiotensin the second receptor blockers, they work a little differently. They block the action of angiotensin the second at the receptor level.
So they don't prevent it from being made, they block its effects? Smart.
Yes. Just like with ACE inhibitors, we adjust the dose based on kidney function. Losartan, for example, a common ARB. Normal kidney function, you might start at 50 milligrams once daily. But if CRCL is 30 to 50, probably reduce the dose to 25 milligrams once daily. And CRCL less than 30, we might think about a lower starting dose or different medication.
Protect the kidneys. It seems like that's a recurring theme in cardiovascular pharmacology. Renal adjustments are key.
You're absolutely right. Now, another important class of drugs, beta blockers.
Beta blockers, they block those fight-or-flight hormones. Epinephrine or epinephrine, calm the heart down, slow the heart rate, reduce blood pressure.
Excellent summary. Metoprolol, Carvedil, bisoprolol, those are some common beta blockers.
Renal function, important for dosing, I assume.
Yes, absolutely. For example, metoprolol. Normal kidney function might start at 25 milligrams twice a day, but if CRCL is between 15 and 30, reduce to 12.5 milligrams once daily, maybe even every other day. And if it's below 15, even lower starting dose. Or a different beta blocker that doesn't rely as much on renal clearance.
Always thinking about those kidneys, making sure we're not putting too much stress on them.
Exactly. Now, let's talk about calcium channel blockers, another essential tool in cardiovascular medicine.
Okay, calcium channel blockers. They block calcium channels in the heart and blood vessels. Relaxation of the blood vessels, slower heart rate. Anything special we need to know about renal function with these?
We adjust the doses based on renal function, just like with the others. Amlodipine, a commonly used calcium channel blocker. Normal renal function, typical starting dose might be 5 milligrams once daily. But if CRCL is below 30, we might reduce it to 2.5 milligrams once daily, or choose a different medication.
Okay, so renal adjustments, that's a consistent theme when prescribing these medications.
You're absolutely right. Now, nitrates. Particularly helpful for angina. They dilate the blood vessels, improve blood flow to the heart muscle.
Like opening of those clogged pipes. More blood to the heart. How does dosing work? It's especially considering renal function.
It varies. It depends on the formulation and the individual patient. Sublingual nitroglycerin, the typical dose is 0.3 to 0.6 milligrams, taken as needed for chest pain. For long-acting nitrates, we often adjust to provide continuous relief, minimize tolerance.
More nuanced than some of the other drug classes we've talked about. Renal function, does that play a role?
Nitrates aren't usually cleared by the kidneys, but we still need to think about renal function. Kidney problems can worsen some of their side effects. Low blood pressure.
So it's all connected. Kidney health is a factor.
Right.
Even for drugs not metabolized by the kidneys.
Exactly. We have a lot more drug classes to talk about. Antiarrhythmics, diuretics, antiplatelet agents, anticoagulants, even thrombolytics. But maybe we should pause here for now, continue in the next segment.
That sounds like a good plan. We've covered a lot today. From those basic hemodynamic parameters to the complexities of managing septic shock. And we've started to explore cardiovascular pharmacology with a focus on renal adjustments.
Fascinating journey so far. There's so much more to learn. We'll pick up right where we left off in part 2. Welcome back. Let's jump right back into cardiovascular pharmacology. Lots more to uncover.
I'm ready. Last time we talked about those big players, ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and nitrates. We talked a lot about making adjustments when there are kidney issues. What other drug classes are essential here?
Let's delve into antiarrhythmics, the medications we use to manage irregular heart rhythms.
Okay, I know irregular heart rhythms can be really serious. So understanding how we manage them pharmacologically, that's crucial.
You got it. Antiarrhythmics are vital. They treat all kinds of abnormal heart rhythms, from atrial fibrillation to ventricular tachycardia, the more serious stuff. They work by targeting different ion channels in the heart's electrical activity, help reset the rhythm, make sure those signals are firing in the right order.
So they're like, what, conductors? Making sure those signals flow smoothly.
Exactly. And to understand this complex class of drugs, we use the von Williams classification. It divides antiarrhythmics into 4 main classes based on how they work.
Oh, the von Williams classification. I remember that. It's like a filing system for antiarrhythmics.
Right. Class I, they're sodium channel blockers. Slow down those electrical impulses in the heart, stabilize those crazy rhythms.
Like hitting the brakes on those signals.
Exactly. Now, within Class I, we have 3 subclasses, IA, I, and IF, each with subtle differences in their effects.
Okay, nuances. Bring them on. Let's start with Class. What makes them tick?
Class IA drugs, like percanamide and quinidine, they slow down conduction, and they also prolong that refractory period. Makes it less likely to fire off those rapid, uncoordinated beats.
So like giving the heart a longer time out before it can fire again.
Right. Then we have Class E drugs like lidocaine and mexiletine, a bit different. They mainly affect the ventricles, the lower chambers, stabilize rhythms coming from there.
More targeted towards ventricular arrhythmia.
Yep. And then there's classic, flecainide, and propafenone, strong sodium channel blockers, but they don't really affect the refractory period. They're especially good for supraventricular arrhythmias, coming from above the ventricles in the atria.
So each subclass has its own thing, its own applications. I'm guessing kidney function plays a role in dosing here too, right?
Absolutely. Always crucial, especially with antiarrhythmics. Many of them are cleared by the kidneys. Procainamide, a Class IA drug, we adjust the dose based on creatinine clearance, lower CRCL, lower dose, prevent buildup, potential toxicity.
Monitoring those kidneys, adjusting as needed. Safety first. Now what about Class 2? What do they do?
Class 2, those are our trusty beta blockers. We talked about them before. They block epinephrine and norepinephrine. Slow heart rate, less force of contraction, super helpful for certain arrhythmias.
Right, the calm down drugs. I can see how that would help a racing heart.
Exactly. And we already talked about adjusting those doses based on kidney function, so we won't repeat ourselves. On to Class 3.
Class 3. How are these different?
Class 3, potassium channel blockers. They make the heart's action potential last longer, slow down the repolarization phase.
Different part of the electrical cycle, but still helps to regulate the rhythm. What are some examples?
Amiodarone, sotalol, and dofetilide, all Class 3.
And those kidney adjustments, they're important here too, right?
Oh, absolutely. Almost all antiarrhythmics need renal adjustments, even Class 3. Amiodarone, for example, we often adjust the dose based on renal function. Lower CRCL, lower dose. Prevent buildup and side effects. Amiodarone has a long half-life, hangs around in the body for a while.
Makes sense. Those kidneys are always on our minds. Now on to Class 4. What's their story?
Class 4 are calcium channel blockers. Remember those?
Blocking those calcium channels, slowing down the conduction.
Exactly. And like we already talked about, we adjust our doses based on kidney function. Same as when we use them for hypertension, angina, whatever.
Okay, so renal adjustments, they apply across the board. Got it.
Yeah, diuretics. Another essential class in cardiovascular medicine.
Diuretics. I know these guys. They help the body get rid of extra fluid.
Right. Essential for managing heart failure and hypertension. Conditions where fluid overload can be a big problem. They increase urine output, reduce fluid buildup, relieve pressure on the heart and blood vessels. Think of it like flushing out the system.
Like a detox for the heart. Now, there are different types, right? Each one working on a different part of the kidneys. What are the key differences?
Sure. One of the most common types, thiazide diuretics, like hydrochlorothiazide and chlorthalidone. They work in the distal convoluted tubule of the kidneys. Inhibit reabsorption of sodium and chloride. Increase urine output.
So they stop the kidneys from holding on to salt and water. Gets flushed out. Reduces blood volume. Lowers blood pressure.
Precisely. Another powerful type, loop diuretics. Furosemide and bumetanide. They work in the loop of Henle. different part of the kidneys, inhibit reabsorption of sodium, chloride, and potassium.
Different part of the kidneys, same goal. Increase urine output. Reduce fluid overload.
Right. And then we have potassium-sparing diuretics like spironolactone and amiloride. They conserve potassium while increasing sodium and water excretion.
So good for patients who might develop low potassium from other diuretics.
Yeah, exactly.
Yeah.
Now, you guessed it. Renal function is key when dosing diuretics.
I was just going to ask about that. It seems like we're always thinking of the kidneys. How do we adjust diuretic doses based on kidney function?
Good question. Let's start with thiazides. Hydrochlorothiazide, typical starting dose, normal kidney function, maybe 12.5 to 25 milligrams once a day. But if their CRCL is below 30, we might reduce the dose or use a different diuretic.
So cautious with thiazides in patients with kidney problems. What about loop diuretics?
Loop diuretics, furosemide, for example. Normal kidney function, you might start at 20 to 40 milligrams once daily. But CRCL below 30, reduce the dose to 10 to 20 milligrams once daily, maybe even less. Depends how bad the kidney problem is and how they're responding.
It's amazing. We're always fine-tuning those doses. It's so important to think about the whole patient. All these systems are connected.
Couldn't agree more. Now, antiplatelet agents. They prevent blood clots, inhibit platelet aggregation.
Antiplatelet agents, right.
Yeah.
Essential for those thrombotic events, heart attacks, strokes. They target different pathways involved in platelet activation, make those platelets less sticky, less likely to clump together.
Yep, preventing those clots.
Yeah.
But they use different mechanisms.
Got it. Different approaches. So what are some examples, and what about renal adjustments?
Aspirin, one of the most well-known, preventing heart attacks and strokes, inhibits the production of thromboxane A2. That's a substance that promotes platelet aggregation.
So aspirin just stops that whole process, prevents clots from forming in the first place.
Exactly. We also have clopidogrel, prisugrel, and ticagrelor. They block different pathways.
All about those platelets, but with slightly different methods. What about renal adjustments?
Most antiplatelet agents aren't eliminated by the kidneys, but we still need to think about renal function. Kidney problems can make bleeding more likely.
Right, so even if they don't directly affect the kidneys, there can be interactions.
For sure. Now, anticoagulants, another essential class, preventing clots.
Anticoagulants.
Yeah.
Warfarin, the classic one, needs regular blood monitoring. How does warfarin work? Does renal function affect how we use it?
Warfarin, it's a vitamin K antagonist, inhibits certain clotting factors in the liver, good for preventing and treating thromboembolic events, deep vein thrombosis, pulmonary embolism, things like that. But it needs careful monitoring, INR testing, make sure the dose is right.
Because too low, it might not work. Too high, there's a bleeding risk.
Yep. But now we have newer anticoagulants, DOACs, direct oral anticoagulants. They're getting more and more popular.
That makes them better than warfarin. Are they more convenient? Safer?
DOACs have several advantages. No routine blood monitoring, fewer drug interactions, faster onset and offset of action.
So they're easier to manage and possibly safer. What are some of the commonly used ones?
Rivaroxaban, apixaban, edoxaban, and dabigatran. They each target specific clotting factors, either factor Zado or thrombin.
Very targeted. And what about those renal adjustments?
Just like with the other medications, we need to consider renal function when dosing anticoagulants.
Can you give us some examples?
Rivaroxaban, preventing blood clots after hip or knee replacement. Typical dose maybe 10 milligrams once a day, but CRCL between 15 and 50. We might reduce it to 15 milligrams once daily for the first 21 days, then 10 milligrams. And if it's below 15, we usually don't recommend rivaroxaban. Too much bleeding risk.
Again, being cautious with kidney issues. What about apixaban?
Same idea. Apixaban, stroke prevention in patients with atrial fibrillation. Typical dose, maybe 5 milligrams twice a day. But if CRCL is between 15 and 29, reduce it to 2.5 milligrams twice daily. And if it's below 15, even lower dose or a different drug.
Adjust the dose. Protect the kidneys. It's everywhere in cardiovascular pharmacology.
It really is. Finally, let's touch on thrombolytics, medications that dissolve blood clots that have already formed.
Thrombolytics, those are for emergencies, heart attacks, strokes.
You got it. They convert plasminogen to plasmin, an enzyme that breaks down fibrin. Fibrin is the main component of blood clots. They're like clot busters.
Restoring blood flow. When time is of the essence, what are some commonly used ones, and how do we dose them when someone has kidney problems?
Alteplase, often called TPA, given intravenously to dissolve clots. Acute myocardial infarction, pulmonary embolism, ischemic stroke.
Does kidney function influence how we dose it?
Thrombolytics aren't usually cleared by the kidneys, but we still need to consider renal function. Kidney problems, higher bleeding risk. We keep a close eye out for bleeding, adjust our plan as needed.
Okay, so even if they don't directly affect the kidneys, kidney health is still a big factor.
Exactly. We've covered a lot in this segment. Antiarrhythmics, diuretics, antiplatelet agents, anticoagulants, thrombolytics.
That was a lot. But I'm starting to see how these drug classes relate to each other. And yeah, renal adjustments are definitely important.
It is a lot to learn, but you're getting it. And remember, we're just scratching the surface. Cardiovascular pharmacology is a huge field, always changing.
I'm feeling like a cardiologist in training. Now, how does all this apply in the real world? Can we do some case studies? Quiz questions.
Great idea. Maybe in the next segment, we can look at some real-life clinical situations, see how all of this comes together in practice.
Back again. Ready to put all this knowledge into action. Cases, quiz questions. Let's do it.
All right, let's start with a case from those practice questions we talked about. You're called to the ICU. A patient with septic shock from a bad leg infection. They got oxygen, broad-spectrum antibiotics, and a lot of fluids. 5 liters of normal saline.
Okay, so the standard initial treatment, I'm guessing there's a twist?
They're not stable. Blood pressure 9245, heart rate 132, already on norepinephrine 14 micrograms per minute.
That's a high dose. They're not responding well to the fluids and norepinephrine. What else do we know?
Central venous pressure is up 12, urine output low, 0.3 millikey at hour, lactate 7.4. Heart function looks okay, though.
Okay, so septic shock, not responding well. What's the next move?
This is where we think about those different vasopressors. Remember vasopressin, for patients who aren't responding to norepinephrine.
Right. It can help with the blood pressure. Maybe we can lower the norepinephrine dose, too. Less chance of side effects.
Exactly. We'd start vasopressin, low dose, 0.03 units per minute, and titrate based on the blood pressure.
Makes sense. Better blood pressure control, lower norepinephrine dose, less risk of complications. Okay, bring on the next challenge.
All right, let's test our knowledge of diagnostic testing. Coronary artery disease. Here's the question. Which test is best for ischemia? In a patient with low to intermediate risk of A, echocardiogram, B, left heart cath, C, cardiac stress test, D, cardiac MRI.
Thinking about risk level and how invasive each test is. I'm going to go with C, cardiac stress test.
Right. Cardiac stress test, the most appropriate for this patient. Not invasive. Tells us how the heart responds to exertion.
Less invasive for someone who's not high risk. What about those other options? Why not those?
Echocardiogram. It shows heart structure and function, doesn't directly assess ischemia, left heart cath invasive, usually for higher risk patients, or if a less invasive test, like a stress test, shows something's wrong. Cardiac MRI, powerful tool but more expensive, not as readily available.
Stress test is a good balance then. Good information, low risk. Okay.
Resistant hypertension, patient, history of hypertension, diabetes, and chronic kidney disease. Blood pressure is still high, even though they're taking hydrochlorothiazide 25 milligrams daily, amlodipine 10 milligrams daily, and lisinopril 40 milligrams daily.
Resistant hypertension. Tough to manage.
What would you add to their regimen? A, terazosin 2 milligrams daily, B, spironolactone 25 milligrams daily, C, clonidine 0.1 milligrams twice daily, or D, chlorthalidone 25 milligrams daily.
We need to lower blood pressure, but not make the kidneys worse. No bad interactions with their other meds. Diabetes and kidney disease, we have to be careful. I'm thinking B, spironolactone 25 milligrams daily.
You got it, spironolactone. A mineralocorticoid receptor antagonist. Great choice for resistant hypertension. Lowers blood pressure, and it can actually protect the kidneys. Important for this patient.
So better blood pressure and kidney protection. Why not the other options?
Terazosin, an alpha blocker, not usually first line for resistant hypertension. Clonidine can cause drowsiness, other side effects. Might not tolerate it well. And chlorthalidone, another thiazide, adding that to hydrochlorothiazide, not a good idea. Similar mechanisms, more side effects, not much more benefit.
Spironolactone is the most strategic choice then. Safest too. I'm ready for another one.
Okay, heart failure. 64-year-old man. Non-ischemic cardiomyopathy, shortness of breath, getting worse. Which of these findings would make you think it's volume overload? A, an S2 heart sound. B, jugular venous pressure of 8 centimeters of the sternal notch. C, wheezes on lung auscultation. D, a negative abdominojugular reflux test.
Looking for fluid buildup. To explain the shortness of breath, S2 heart sound, normal. Wheezes, that's more like asthma, COPD. Not volume overload. Negative abdominojugular reflux doesn't rule it out. So I'm going with B, Elevated JVP.
Exactly. Elevated JVP, classic sign of volume overload in heart failure. Increased pressure in the right atrium, fluid backing up from the ventricle.
A visual clue. Tells us how much fluid is backing up.
Right. Physical exam, history, other tests, they all help us figure out what's going on.
Okay, I'm feeling confident. One last challenge.
Last one. Mechanisms of arrhythmias. What's the most likely cause of atrial fibrillation? A. Accelerated AV conduction. B. Circus movement. C. Abnormal automaticity. D. Sinus arrhythmia.
Atrial fibrillation. Common. Lots of trouble for patients. Accelerated AV conduction, signals moving too fast. Not the main thing in atrial fibrillation. Circus movement can cause some arrhythmias, but not usually this one. Sinus arrhythmia, that's normal, related to breathing. So that leaves C, abnormal automaticity.
That's it. Atrial fibrillation, usually caused by abnormal automaticity. Impulses starting in the wrong places in the atria, those rogue cells firing off signals, disrupting the rhythm, chaos.
A wild party in the atria. The rest of the heart trying to keep up.
Good way to picture it. So, abnormal automaticity, that's our diagnosis.
I've really enjoyed this, putting all our knowledge to the test. Hemodynamics, sepsis, cardiovascular drugs, it all comes together.
It's been great diving into this with you. So much to learn, but you're getting it. Remember, cardiovascular medicine is always changing. Keep learning.
Will do. And to our listeners, thank you for joining us on this deep dive. We hope you've enjoyed it. Until next time, stay well.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Where great minds meet. We're so glad you're listening. Where Great Minds Meet brings together visionary guests. From Chancellor Gary May and Dr. Robert Langer to Greg Zuckerman of the Wall Street Journal and Forbes 30 Under 30's Kyle Wum. To share insights on science, leadership, and purpose. Featuring pioneers like His Excellency Sidney Colley and Dr. Emery N. Brown. Each episode dives into stories of resilience, discovery, and impact, celebrating the intersections of curiosity and greatness across diverse fields. Thanks for listening. Please note the views of this podcast reflect those of my guests and I. Also, please consult the relevant state and board-certified professionals for advice or consultation. Once again, thanks again for listening.